Hello and welcome everybody to today's e-seminar, which is the second case conference of the EUROT, which is an initiative by CKD-MBD. I'm very happy to present to you the speakers. The speaker today will be Hanne Skou Jørgensen. And she is associate professor of nephrology at Haarhaus University. We also have with us the panelists, three panelists. Pieter Evenepoel, who is associate professor of nephrology at the Catholic University of Leuven. We have Syazrah Salam, who is an honorary senior lecturer at the University of Sheffield. And we have Poole, who is a professor of metabolic bone disease at the University of Cambridge. And all our speakers and panelists today are also clinically active nephrologists. I myself am affiliated researcher at Karolinska University Hospital and Karolinska Institutet. So next slide, please. The case conferences have been started by EUROT, and EUROT is an initiative of the CKD-MBD working group of the European Renal Association. EUROT started in 2017 as an initiative of physicians and researchers with a special interest in bone diagnostics and even more special interest in bone biopsies. So the original idea was to bring bone biopsies closer to the clinicians into the clinical practice and to establish a network, a European network, to facilitate bone diagnostics, including bone biopsies, as a clinical tool. And it consists of two different sections. One is a large European registry of bone biopsies. So as many participants as possible in Europe have the possibility to send their biopsy data to a large registry that is then the basis for bone biopsy related research. And currently this registry contains more than 750 bone biopsies. It's a virtual registry, so it doesn't contain the actual biopsies, it contains data. We also have a clinical network where we originally started to discuss cases within EUROT, within the group of the EUROT members, but this year we felt it was time to take the step outside and include even external listeners and external audience. So that's why we now have the second case conference, and it's made available as an e-seminar through the ERA webpage. We are very thankful for that. We can take the next slide. So EUROT also has, due to its very strong clinical profile, we also have the intention to give guidance to, or at least to give support to clinicians who are handling patients with complicated CKD-MBD. So we have the ambition to write consensus papers dealing with difficult questions. And one of the first consensus papers we wrote was on the European consensus statement on the diagnosis and management of osteoporosis in advanced CKD, G4 to G5D. This was together with the IOS. A second recommendation came out this year, is the recommendation on calcium intake in adults and children with chronic kidney disease. So the plan is to continue with additional consensus statements yes, and we can also say that these papers are highly cited, so we have a feeling that we really fill in a gap. So the calcium intake is already cited 99 times. So please, we go on. And here we are at today's case presentation. So Hanne, I would like to ask you now to share your case with us. It's a real life clinical case. I think this is important to keep in mind because there are educational cases, very streamlined, but this is a real life clinical case, a patient that we all probably are confronted with. And I think it very clearly demonstrates us the complexity of CKD-MBD in the clinical everyday work. So please, Hanne.
Thank you. So this was a case of a 54-year-old woman with polycystic kidney disease as the cause of kidney failure, who had been receiving hemodialysis therapy since 2011. So really a very long time on hemodialysis, 12 years, and she was quite young when she started hemodialysis therapy. And for these 12 years, we've been trying very hard to get her further on and to receive a kidney transplant, but we have not yet succeeded, mainly due to multiple comorbidities and complications. So the clinical problem of this case is that in November 2022, she has sudden severe back pain. And initially, she's worked up with an MRI of her spine, which reveals these collapsing end plates of vertebral level L3 and L4. And this was followed by a plain X-ray, which confirmed the findings. You can see here on L3 and L4 that we go from having this nice square vertebral shape to having a clear indentation of the vertebrae in the middle portion here. So this was conservatively managed, and initially she improved, but then in January 2023, she had again severe back pain, and another X-ray was taken revealing a vertebral fracture at TH12. And I've just kept this previous image here to show you that TH12 is in this image fairly nice and squarely shaped. And then in the next image, we see that it is completely collapsed and wedge-shaped in addition to the two previously deformities. And then finally, in June 2023, her physiotherapist noted that her spinal column looked sort of asymmetrical, looked like part of her spinal column was shifting towards the right. And she had another X-ray performed which showed that L2 had collapsed. And when we looked at the anterior posterior image, it was particularly collapsing in the right side. And the radiologist noted that this was causing a shift of the more proximal or more cranial levels of the vertebrae towards the right. So this was the cause of this apparent asymmetry that was noted by the physiotherapist. So this is a patient who has had a rather complicated history also with relation to CKD-MBD. In 2013, she had a subtotal parathyroidectomy due to severe secondary hyperparathyroidism with PTH levels up towards 1,000 picograms per ml. In 2016, she had calciphylaxis with mainly very painful subcutaneous nodules of her thighs and her lower legs, and she had treatment for 2 years with intensified dialysis therapy, optimized mineral metabolism therapy, and also optimized medical therapy overall, and sodium thiosulfate, and she got through that. And then in 2020, she was discovered to have ischemic heart disease. She did not have a myocardial infarction, but rather more insidious symptoms that when worked up revealed coronary arteriosclerosis, and she had 2 stents put in. This was her current CKD-MBD therapy just at the point where she had these vertebral fractures. She got alpha-calcidol, which is the favored active vitamin D compound used in Denmark. She got a fairly high dose of cholecalciferol once monthly, in addition to a smaller dose daily with her calcium carbonate, which in this case is given as a calcium supplement, likely started at the time of her parathyroidectomy, which is our usual standard. She also got a calcium-containing phosphate binder in the form of calcium acetate combined with magnesium carbonate 2 times daily, and then she got lanthanum carbonate as needed. And the way that works is that she has monthly labs, and then the nurses of the dialysis unit will tell her whether she needs to increase her phosphate binder therapy or not. So these are her current or her trends of her CKD-MBD related biochemical data. This is her PTH levels. You can see that she does still have parathyroid function, but her PTH levels are generally in the normal range, and they've not been above 2 times the upper normal limit of the assay for the past 3 years. Her vitamin D levels are consistently in the normal range and rather high in our target range. So our target range is about 50 to 125 nanomoles per liter. Her calcium is in the normal range, but rather fluctuating. And you can see here that in 2020, she had an episode of severe hypocalcemia, which was attributed to malabsorption. It was just after she'd had a gastric balloon installed. And then phosphate is currently well controlled, but has not been so in the past, and particularly in the time period when she had calciphylaxis, she had very severe hyperphosphatemia. And then she has had a lot of comorbidities that has given us some troubles, especially with regards to kidney transplantation. She's been severely obese with a start BMI above 40 and a weight starting at 135 kilos. During the past 3 to 4 years, she's had an intended weight loss of 50 kilos, so she now weighs in the mid-80s. And this has been by the help of a gastric balloon, orlistats, and also GLP-1 analog. She has asthma and she takes inhalation therapy for this. She has ADHD and she takes Ritalin for that. Sometime during her course of dialysis therapy, it was discovered that she has antiphospholipid syndrome due to recurrent clotting of her AV fistula. And so she was on vitamin K antagonist for a while. But of course, this was stopped when she had calciphylaxis and she was switched to low molecular weight heparins. She's also had recurrent episode of joint pain, and she's been worked up through the rheumatology department. They've not been able to set a diagnosis for her, and the X-ray are mainly consistent with arthrosis, but they do note that she is chronically inflamed, and her CRP levels do seem to increase slightly when she has episodes of joint pain. During this 2-year period when she was worked up for joint pain, she did have several courses of oral glucocorticoids, typically in the dosages of 20 to 40 milligrams a day for a couple of weeks duration of time. She had breast cancer in 2022, which was a small tumor with no metastases. It was managed with surgery and post-surgery radiation therapy, and she actually declined anti-hormonal therapy for this. She had, as I said, cardiovascular disease and gets relevant medical therapy for this. She also gets a PPI. I'm not sure of the indication, but I've listed it here. She has CKD-related anemia for which she gets IV iron, typically 100 milligrams a week. She gets B12 and some regular dialysis-related vitamins, and she is not on any EPO agents. And then since she had her vertebral fracture, she's also on some analgesics, mainly fentanyl as a dermal patch, with the possibility of taking extra OxyContin as needed. So that was the case quickly summarized. A fairly young patient in my optics who has been on very long-term hemodialysis therapy. We've not been successful in getting her a kidney transplant due to multiple complications and comorbidities. She's had a rather complicated course when it comes to CKD-MBD. Her obesity has been a problem, particularly in getting her a kidney transplant, but she's now achieved a substantial weight loss. And she also has chronic low-grade inflammation and this possible arthritic condition. We also know, because she's undergone quite a lot of imaging, that she had no vertebral fractures in June 2021. You can see her spinal column here to the right. And then in August 2023, when this case was first brought to a multidisciplinary team conference, her spine is very changed. So these are the questions that I have for the panel. So what do you consider the likely mechanism or underlying cause for this patient? Do we need any further investigations to elucidate any causes? How would you treat the patient? Would you optimize mineral metabolism, and if so, how? Or would you start a bone targeting therapy, and if so, what? So I thought we could take them one by one. So the first question would be then, what would you consider the likely mechanism or underlying cause?
Thank you very much, Hanne, for this excellent case presentation. I think it is really a real-life case. So I'm very happy that we have real-life doctors on the panel. And let's now hear your opinion about this patient, about this treatment. Let's start with the first question. Pieter, maybe you can give the first response.
Thank you for this very interesting case. So this is really a case that you could see on your outpatient clinic, and you would immediately think this is a case where I need to do something, because this is really like severe osteoporosis, and by no question this is osteoporosis. These are spontaneous fractures in a 54-year-old lady. So you many fractures also with invalidating consequences. So that's really a patient that you need to do something. Then, of course, the question starts what to do, because this is a complex case, a patient on haemodialysis with really osteoporosis and probably also low bone mineral density, although we didn't get the results of the DEXA scan. But this is a patient with most likely a premature menopause. I mean, she was 50 years and she got dialysis already for 14 years. So I can imagine that this lady was a lady with a premature menopause. So it would be nice to know the age of her menopause, because this could also be additional risk factor for low bone mineral density in this patient. Second, she had an episode of calciphylaxis, which is a highly inflamed disease, bed rest at that time. And both conditions, so both inflammation and bed rest, certainly could contribute to low bone mineral density. Also, she got an episode before of severe secondary hyperparathyroidism, for which she got surgery. So also high PTH for a long time could also have caused some bone mineral density loss over years. So this is certainly a patient with a high risk of a low bone mineral density, which is, as we all know now, this is also an accepted risk factor for fractures in patients on dialysis. So I would certainly do something, but before, let's say, discussing the therapy, I would also like to know in this patient her calcium intake. She has been obesity. She got a gastric balloon. She lost more than 40 kilograms the last years. She's also on Orlistat, which could also compromise her calcium absorption together with the PPI. So I would like to know also what is her calcium intake, and are we sure there is no calcium malabsorption in this case? And with this, I would like to stop at this moment, and I would like also ask Jaja what she thinks about this case.
Yeah, with her history, I mean, the background history in terms of her CKD and dialysis, I wouldn't be surprised, you know, she's got renal osteodystrophy and osteoporosis as the likely mechanism of her fractures. And you know, if you are looking for a case where there is imminently high fracture risk, this would be one, because she is literally having a fracture every few months in front of your eyes. Jordi already mentioned it in the Q&A as well, and that is with or without steroid, she is fracturing. The other mechanism is, of course, with the steroid as well, this may be glucocorticoid-induced osteoporosis. And also with that much weight loss of 50 kilogram, she is likely to have lost bone as well with that weight loss. So all in all, I would say renal osteodystrophy and osteoporosis and very high fracture risk. And I agree with Pieter, we should think about treatment and how we're going to, you know, decide on what treatment to have.
Thank you very much, Jaja. Very, very good comments from both of you, Pieter and Jaja. Ken, I would like to hear your comments about this case and what can be the underlying cause.
Yeah, thank you. And thank you for inviting me onto the talk amongst the renal physicians. For us, this is somebody we would love to have seen round about 2013 when she had her 1,000 parathyroid hormone and a parathyroidectomy, and we would hope to have got a forearm DEXA to assess her cortical bone, spine and hip bone at the time. I don't know whether that's going to be shown to us later. I'd hope the first DEXA wasn't done around this time, because this is really going to be shutting the door after the horse has bolted, as we say, because for us, severe grade 3 vertebral fractures are the worst thing that can happen in osteoporosis, worse than, say, a hip fracture for our patients and the effect on their lives. And having them every 3 months is a real disaster. And when you look through the causes, not only if it's polycystic kidney disease, the ciliary dysfunction in osteocytes causing a basal problem in the bones, and an osteoblast deficit, the osteoblast deficit from repeated steroids, the osteoblast and osteoclast deficits, and activation of osteoclast from excessive weight loss, possible IV iron effects from phosphate issues, and resulting in domino fragility fractures of the spine. It's very difficult to pick a pathology. And the other thing to say is that with the sort of the bow tie appearance of the biconcave fracture that she has there at L3, we're not even convinced that, despite the excellent efforts of giving vitamin D and compounds like that, we're not convinced about the underlying level of mineralization in this woman's skeleton. So this is the perfect storm, and wonderful to be presented with this, and terrible for the patient.
Thank you very much.
Yeah.
Definitely. And I can add a question from the panel. Maria-Len asks, what about pyrophosphate as an additional cause for the osteoporosis? So could you please comment on this?
Yes, I think I have a rheumatologist hat as well as metabolic bone disease, and yes, absolutely. One hopes she would have had a full workup for pyrophosphate disease. There's nothing on the images we've been shown, but this is certainly might be responsible for some of her peripheral joint effects, particularly given the history of the hyperparathyroidism. And it's certainly, that gout, pseudo-gout, there is a lot to pick apart. You've also mentioned antiphospholipids, so there is connective tissue disease elements and possibly Hughes syndrome parts to this. So a rheumatologist has already been involved in her care, and I hope will have thought about these things too. Yes, thank you. All the questions are just rolling in. Proton pump inhibitors is a comment, and this is of course also one of the reasons that we should take into account. So as you say, a perfect storm, I think that's a perfect description. So it's more or less a surprise that the patient has not fractured before. And there was one question here about the management after the first fracture. So you said it was conservatively managed, but of course the first fracture already put this patient with a very high fracture risk at an extremely increased fracture risk. So I think this is also a question, should management have been different in the beginning? But we will come to the management questions, I think, if we go ahead.
Yeah. So this is just to sum up on this part. This is how it looks like in my mind, to keeping in mind that there can be many different contributors to bone disease in our patients, and not just always focusing on the arrhythmic factors. Of course, she's had a very long and complicated course, and this has definitely contributed, but also aging and premature aging. And we briefly mentioned premature menopause, hypogonadism also in relation to premature menopause. How about muscle strength and function and lifestyle factors and so on? She's had a large weight loss. Can this be contributing to her osteoporosis? Common drugs, she takes PPI, she's been taking glucocorticoids, all things that can affect bone quality, and she has probably some sort of ongoing inflammatory condition, which can also be a big drain on her skeleton. And then when it comes to renal osteodystrophy, Jaja briefly mentioned that she thinks in her head this is renal osteodystrophy, which is a metabolic bone disease. So something specific to uremia may also be going on here. So could it be a low bone turnover state, considering that she has had low PTH levels for a long time? Certainly, we could be worried that she has low bone formation due to glucocorticoids and this cilial condition. And then it's the dreaded mineralization defect. Could she be one of the patients who has a mineralization defect with these multiple fractures in a short time period. And then for sure, I think she has a lot of pre-existing damage to her skeleton with this severe secondary hyperparathyroidism that she has had going on, and glucocorticoid courses and so on. So very likely low bone volume and very poor bone microarchitecture. So to the questions that were asked, I don't know her calcium intake. I know that for a long time, the dietitians at my hospital advised sort of the traditional way, saying you should avoid phosphate-containing foods such as dairy products and so on. And so she could well be a patient who gets very little calcium in her diet. But for us, after parathyroidectomy, it will be standard to start a patient on alpha-calcidol and calcium carbonate and to keep that going lifelong, and then adjust dosages so that she has calcium in the normal range. So at least she has been a bit protected that way with a calcium supplement for many years. We did see this severe hypocalcemia in 2020, probably related to malabsorption shortly after she got her gastric balloon, where we then adjusted therapy and ended up in some sort of stable condition again. And
do we have any idea on the impact of the orlistat on the calcium absorption? Because that's something I'm not aware about, because it's, of course, lipid, and lipids bind calcium. Is this something that the other panelists have ever seen, this kind of interaction between orlistat and calcium malabsorption? Not really, no.
No. As to the management, I think everyone was a bit stumped after the first cause of vertebral fractures. We have been also very hands-off with anti-osteoporotic therapy for our dialysis patients. We do not DEXA scan our dialysis patients with any regularity. We also did not perform a DEXA scan at the time of the parathyroidectomy or at any other time point before these fractures happened, because we've been very unsure how we should treat these patients. We recently started a multidisciplinary team approach at my hospital, which has really helped a lot in getting away from this treatment nihilism of just letting people be with their osteoporosis in dialysis.
Thank you very much. So, yes, Hanne, you want to go on, or?
Yeah,
I think we should at least ask the panel if you want to have any additional investigations. So, Jaja, do you want to comment on this?
Yeah, you've given the answer.
These are the options. I just wanted you to keep in mind. We do not perform bone biopsies in this center.
Yes.
I certainly want to know her bone mineral density. The reason for that is that I expect her to have osteoporosis or osteopenia, but just in case her bone mineral density is completely normal, then we need to think of other strategy, because it may not be something, you know, related to bone mineral density impairment. Because whatever treatment that we're going to discuss about later, all the limited data that we have is in terms of improvement in BMD and hopefully reduce fracture risk. But if BMD is completely normal, we need to think, is this something to do with bone quality? Is this bone mineralization abnormality, such as osteomalacia? In terms of other imaging, in the real world, I haven't got any of the other, you know, HRPQCT access, so I won't be doing that. Biochemistry, I think you've gone through quite a lot there in detail, but certainly I'm going to start thinking about bone turnover markers. The ones that we use in clinical practice would be bone alkaline phosphatase. But of course, we also need to be aware of the fact that bone turnover markers are high, particularly within the first 6 months after a fracture. So that might affect the reading. And then we are in a slight difficulty about how we interpret that with regards to what treatment we could potentially offer this patient. So as you said, bone biopsy is already not available in this particular center. But in my center anyway, we are trying to use bone turnover markers first. And if there is any problem with interpretation with that, then we may consider bone biopsy.
So may I just have give you a follow-up question? In this case, which I mean, often the case is that we get patients with a new fracture. how would you interpret the history of bone turnover markers, specifically for indication of treatment?
Yeah, very good question. So I would normally wait for 6 months, but of course in this patient, we can't afford to wait 6 months, can we? She's fracturing right in front of our eyes. So then I would be looking at the level of the bone turnover markers and whereabout it is in relation to the cutoff levels that have been published before. And I think Hanne will show that later. And also taking into account her weight loss, etc. So it's not easy, Mathias. You know, I can't be absolutely certain that my interpretation will be correct. And that is the difficulty with these cases.
Can I ask, do you have access to a bone resorption marker that you would use for a kidney failure patient?
Just about to ask the question.
Yeah, so we only in research practice, not in clinical practice, unfortunately. We use urine NTX for, this osteoporosis patients, but of course you can't do that when they are anuric. So the answer is no, which is unfortunate, because I think that is really important when it comes to, trying to interpret what's going on with regards to bone turnover.
Any of the
I think
other
it's
panel?
really...
Yes, Ken, please.
Yeah, and I think it's important for the listeners to know that Syazrah's in Sheffield, is that right? And that's the sort of one of the global hubs of assay technology and usage of bone turnover markers. And this points to another issue that there's no easy solution here. And if this patient came to our Cambridge metabolic bone MDT for rare diseases, we would have our renal physician on hand and sometimes visiting renal physician, and we would all unanimously say biopsy in this situation. And that's what the guidelines would say from UROD. And it wouldn't have to be necessarily 7.5 millimeter trephine. It could be a Jamshidi, because the biopsy will give the piece of information that's absolutely critical here, which is there a mineralization defect or not? Yep. Now, it sounds so good to say that here, but we now can't get our bone biopsies for ages because of the enormous post-COVID-19 backlog in orthopedic cases. So we have a huge delay. And so it's going to be very interesting to go on to look through this case without the benefit of the biopsy.
Yeah.
So how long would you accept to wait for a biopsy before you start therapy?
In this case, therapy would have to be taken within the first 2 or 3 months after, because in the situation of dominovertebral fractures, the vertebrae can't take the 2,000 newtons of normal day-to-day living that our vertebrae need to take, and therefore I use an analogy from transplant surgeons here when they transplant somebody and then all of their vertebrae collapse, and they haven't measured a DEXA or anything like this. And I say, well, you've just redecorated the whole house, put in a new boiler and new radiators, but there's a great big split down the middle of the wall of your house. And this is how important it is. So in this case, we would have to go blind flying, as you may have had to have done, but acknowledging that a bone biopsy is pretty much the only way to tell safely how she is. And to be honest, you've also already mentioned obesity necessitating a gastric bypass, which is one of the relative contraindications to a bone biopsy. So as I say, perfect storm, and interested in the next steps here.
Yeah, I agree with Ken that the bone biopsy in this case would be of interest, but as Hanne, alluded to, this is of course not always available. So we have to deal with these patients also in the absence of a bone biopsy. So that makes it more complex, but at least we should not step away and say, because we don't have a bone biopsy, we should do nothing. So at least we need to do something. Even I do agree with you, Ken, that in this case a bone biopsy would be very helpful, also to exclude the mineralization defect. Besides, also the bone biomarkers could be of help, but of course we need to be aware of the confounding effect of the recent fractures, which certainly could impact on the bone turnover marker, so makes it more difficult to interpret the data. And also I would certainly go on with a DEXA scan, not at the least to have a baseline value. If you then start treatment, you could at least follow the effect of your therapy at the end. But the bone biopsy again would be, that would be welcomed with open arms. I agree.
Definitely. And my previous question about the history of the bone markers, I mean, here we have a patient with probably a long-standing skeletal problematic situation with malabsorption, with treatments that interfere. So I think what you could do is look at historical data, has total alkaline phosphatase or has bone alkaline phosphatase being controlled previously. You could look at the previous levels to see if there is indication for, it's not diagnostic, but it could be indicative of a mineralization defect. And you could also look at the current level and see how does it relate to previous levels. Is it severely increased? If it's not increased, at least it can rule out mineralization defect.
Yeah.
But there is a caveat, of course, because bone alkaline phosphatase can come from severely calcified vascular tissue, and this patient has a history of cardiovascular calcifications. She has had.
But having said this, Mathias, looking at this X-ray, there is minimal calcification. So I was a little bit surprised by this case showing almost no calcification, although she got inflammation, she has obesity, whatever risk factors, but still there is not that much calcification on this X-ray, which is astonishing in a way.
It's astonishing. Could it be due to a malabsorption? That she is depleted of calcium. It's very difficult. I mean, this is guessing. Hanne,
and if I may, coming back to your point on the bone biomarkers, I mean, you made a very important point, is looking at trends. I mean, we know KDIGO emphasizing that if we look at PTH, we should not look at one single value, but look at trends. And the same holds true for bone biomarkers. So we should have a look at trends. And again, most people do not have access to this specified test like bone alkaline phosphatase or P1NP, TREP5B, but then we can look at total alkaline phosphatase. Who would like to see this data as well?
All right, let's move on then. So first off, we also decided to do a DEXA as a baseline. So we didn't have a previous DEXA. We don't know how her development has been, but currently she has osteoporosis both at spine and hip. And if I can find the right scores here, she is at minus 3.12 at the spine and at minus 3.3-ish or 2.9-ish at the hip. So she has very low bone mineral density on both these skeletal sites that we measured. And then I just wanted to say that I got a question from the chat from Marie-Hélène asking about multiple myeloma and being careful that these are not osteolytic lesions. And I quickly went back to the labs and said, we actually haven't done paraproteinemia for this patient, but we have done very regular CT scans considering her previous cancer diagnosis, and no osteolytic lesions have been detected. So we have both a regular computed tomography scan and also a PET-CT scan in 2023 without any osteolytic lesions. So hopefully there's nothing we've missed in that. Coming to the biochemical data, what we do have as standard in our center is total alkaline phosphatase. So that has been measured every 3 to 6 months, sometimes more often. And this is from 2019 until summer of 2023. So just after she had her third vertebral fracture here. And it has been sort of high in the normal range and slightly increasing over time up towards the first vertebral fracture. So this is the first vertebral fracture that we know about in November 2022, and this was the last one in June 2023. And if I have put in, we also measured bone-specific alkaline phosphatase just before discussing her and her multidisciplinary team, but this is 2 months after her most recent fracture, so it's not a very reliable measurement. And the problem is we can't really, as has been mentioned, do bone tumor markers as the state is now because she's had her fractures and she continues to fracture. So she had her first fractures in the winter, and so we might have had a clear reading here in the summer, but then she had a new fracture. And so for the next 6 months, we may expect these to be elevated. We do know here in June 2021 that she had no vertebral fractures on her CT scans and also no other clinical fractures. And so these measurements should at least be indicative of a high bone turnover state if you accept total alkaline phosphatase as a proxy for bone alkaline phosphatase. So it's the best that we have because we need to go backwards in the history of this patient. So Ken, maybe I can ask you quickly before we move on, what other bone turnover markers would you consider for a patient on dialysis? Do you have any experience using CTX or total P1NP?
Not in end-stage renal failure. We haven't got access to them. The only two markers we use are CTX and P1NP. And I think, as you've shown, your alkaline phosphatase is probably more useful than those in this situation. So no, we are a biopsying center rather than a marker center.
Yeah, I know there are some nephrologists who use CTX, but I find it difficult to interpret it, particularly if you just do a single measurement, to know if it just expresses their kidney function or any bone resorption.
So if you want to follow CTX because you have nothing else available in your center, you need to look at serial measurements in severe CKD. And I think it's probably easier to interpret in completely anuric patients than patients with residual kidney function. Also, CTX has, of course, the problem that you have a quite strong diurnal variation, so you need to take it in the morning and always at the same time, approximately. So there are some issues with CTX, but it's not impossible.
So this is what we have access to, though. We only have bone-specific alkaline phosphatase. We cannot measure TRAP5B or intact P1NP. So it would be this, and then total P1NP and CTX, which could also be measured.
So one thing, Hanne, that I think is interesting looking at the bulb development before the fractures is that you have an increase that probably starts at some time after the gastric balloon. And what we do see sometimes, especially with these effective treatments for obesity, that we get a malabsorption for both vitamin D and calcium, and this is something driving a hyperparathyroidism. Now, the thyroids cannot really overreact, at least not excessively, but the bulb may be an indicator that we do have some kind of malabsorption here driving an increase in bone turnover.
I think this peak fits fairly well with her episode of hypocalcemia, actually. So it may have been some sort of attempt to draw more calcium out of the bone at that time period. But yeah, so this is one of the things that we put some weight on when making a decision to treat, is that she had increasing levels of total alkaline phosphatase for a while before her clinical fractures. And for any of you having experience with bone mineralization defects, how high would you expect total alkaline phosphatase or bone alkaline phosphatase to be to suspect a mineralization defect? Do you have any sense of where these measurements would be? Jaja?
No sense at all. It's the unknown. If I may just make a couple of comments about bone turnover markers before I forget it. So bone alkaline phosphatase, the interpretation of that depends on what the assay that you use as well. So always check what the assay is, and then you need to find the literature that has looked at diagnostic criteria, whether people have low or high bone turnover based on that particular assay. And secondly, we mentioned quickly about total P1NP, and some centers will be using this, but in advanced CKD and dialysis patients, we should not use it because the monomeric fragments of P1NP accumulate in advanced CKD, so we cannot interpret that in any way. So again, as Ken already said, you know, the really sure way to see what's going on with bone turnover mineralization is bone biopsy, but of course not always available.
Hanne, we probably missed it, but did you report results on the 25 hydroxyvitamin D levels in this case?
Yeah, in the beginning, they're generally high. So last measured here was 160 nanomoles per liter, and the upper normal range for us is 125. So she's above our upper normal range for 25 hydroxyvitamin D.
Okay.
And has been consistently fairly high for the past 2 to 3 years.
And how was her phosphate and calcium?
Phosphate and calcium in the recent year has been fairly well. So she has had normal calcium and she has had phosphate well controlled. So around 1.6 to maximum 1.8. She has had problems with severe hyperphosphatemia in the past, but it's been fairly good for this past year.
Mm-hmm. Excellent. I think we should go on.
Yeah. So let me just get this marker going. So this is just that what Jaja also mentioned. If we want to use the bone turnover markers in a diagnostic sense, there are some recent publications looking at diagnostic cutoffs. In my center, we used immunodiagnostic systems for bone alkaline phosphatase, which was also used in this publication. And the upper normal range of bone alkaline phosphatase for us would be around 27. And here in this publication, high turnover, the cutoff for high turnover was around the same value as our patient has. So based on that, you could also say we suspect the high bone turnover, but it's difficult to interpret because it's taken 2 months after a vertebral fracture. Other biochemical measurements that I have been able to identify from her charts. Here she had her gonadal function assessed at some point, and to my eyes, this looks like she's in postmenopausal states. She is, as I've said, chronically inflamed. Her CRP levels are generally between 10 and 50, going a bit up and down outside of infections. She doesn't have ongoing acidosis. She's on dialysis, and so that's corrected. She has normal TSH. She has also normal liver parameters, and she has a normal magnesium levels. So this is what we have. Anyone wants to comment on the gonadal function? Used to measure it, used to consider it?
She's still on an anti-hormonal treatment, right?
She's not on anti-hormonal treatment. She
Okay.
declined anti-hormonal treatment after her cancer.
Okay.
Why did you measure it? I mean, it's expected, these results, no?
I think they have been measured somewhere else, either by oncology or by rheumatology.
This is at least not part of the routine assessment we have in mind.
Not at all. I've never measured gonadal function in any of my patients.
In male patients, we sometimes do it, but not in females. No.
And this was the slides about inflammation, mainly to remind us that liver alkaline phosphatase can be linked to chronic inflammation. So there is this idea that liver alkaline phosphatase will increase in cases of chronic inflammation. And of course, this will contribute to the total alkaline phosphatase, which is here in the red line with her CRP in the green lines. But I don't see any clear pattern here with regards to her CRP and her total alkaline phosphatase.
So we have a comment from the audience that you can have, especially in obese patients, you can have remaining circulating levels of estrogen. We have also another question. How are iron levels?
They're normal. So she doesn't have high ferritin levels. She doesn't have particularly low TSATs or iron levels or particularly high. She's getting IV iron every week.
Yeah. So now we have done a very thorough workup of the patient, only lacking the bone biopsy. But I think you lead us on to the next and important question. We have a patient with multiple fractures within short time. We need to do something. How should we optimize therapy?
So the two categories that I would identify is, could we optimize mineral metabolism or could we start a bone targeting therapy, and which route would you go?
Mm-hmm.
So please, Pieter, do you want to start?
Well, I mean, if you address a patient with advanced CKD, this is a patient on haemodialysis, so she's advanced CKD. The first thing you have to do is to optimize the mineral metabolism. In a way, her PTH level is low normal. Her calcium and phosphate levels are within target most of the time. Her 25 hydroxyvitamin D is within or even above target, so which is also okay, fine. So from that perspective, I would not do anything. So I would not give active vitamin D, not give calcium mimetic. I would go on with the calcium and the vitamin E supplementation. The only thing is to consider something in addition. So it's to do some kind of specific bone targeting therapy. And then we also look at the bone turnover, and then it's becoming for me a little bit like more difficult. So what's in this patient the bone turnover? Is it normal, high, or low? The bone alkaline phosphatase points to potentially a high bone turnover, but we're not sure about it. Since there's also recent fractures on top, we also, have in mind the possibility of an mineralization defect causing a high alkaline phosphatase. So for me, it doesn't help me that much. So, but still, yeah, we need to do something. And then I would, in this case, I would go on indeed with an anti-resorptive agent.
May I ask you something before we discuss the specific treatments? So we all know very well by now that PTH is not the very best indicator and treatment target for bone turnover, for CKD-MBD. May I ask you, in this case, would you feel comfortable treating her bone alkaline phosphatase, targeting bone alkaline phosphatase with CKD-MBD treatment? Seeing that it's rising during the last year.
Yeah, but again, we're not sure about what's the cause of the rise. Agree? I mean, it could be both the mineralization defect, which is also, I mean, in my opinion, unlikely since calcium phosphate is within the target. There's no acidosis. The 25D was always targeted in the right range. So there is, of course, risk for osteomalacia, but I mean, if you would scale the risk, it's not super high. But it's my opinion. So looking at the others, at Syazrah and Kenneth, whether they share my opinion or whether they have a different opinion.
Yeah, at the moment, in terms of the alkaline phosphatase, I would say it's likely due to bone turnover and fracture healing. Sorry, it's more due to fracture healing rather than osteomalacia. And in terms of optimizing mineral metabolism, yeah, of course, we should do that. That's good practice and that's in the guideline. But none of those treatment would have any evidence in terms of reducing fracture risk. So on top of all that, we still need to think about bone targeting therapy. And looking at the list that Hanne has put down there, I have gone through them in my mind, which one that I cannot give. So is there any one that I can give? So first of all, in terms of bisphosphonate, we don't use it here in dialysis patient. And the anabolic treatment, teriparatide, ideally, we use that in people who have had multiple vertebral fractures, but she has had breast cancer and radiotherapy, so I wouldn't use teriparatide. And romosozumab, of course, has got a signal that is associated with increased cardiovascular events. So in people on dialysis who already have increased cardiovascular risk would not be suitable for romosozumab. And she also actually has had cardiovascular event, hasn't she? So
not
the
recently,
one that
if I'm correct. Was it recently? Because it's the
2020.
labels say within 1 year.
That's 2020.
Oh, but we consider any previous cardiovascular event would be a contraindication, and there is no evidence, of course, that romosozumab would reduce fracture risk. I don't think anyone has studied that. So we are left with denosumab, and then thinking about, again, tailoring that to the bone turnover status. We need to be pretty sure of what the bone turnover is, because at the moment we've got slightly conflicting results with regards to bone alt phos that is borderline, maybe high, but then there is recent fracture, and then PTH, which is not a very robust test, but it has been pretty low for quite a long time since a parathyroidectomy. So that makes me worry that there might be a degree of low bone turnover. So it's very difficult.
So we're also running out of time, so we need to be a bit brief. It's just 5 minutes left. But Ken, do you have anything to add to the treatments?
Yes. So I think everyone said most of what I was going to say. Certainly no to romosozumab, given the absolute contraindication. I think it's very important to find out what the radiotherapy was, whether it was skeletal radiation, which is an absolute contraindication, or whether it was just breast irradiation, in which case teriparatide would be an option for us. We do use low dose or reduced dose bisphosphonates, but in this situation, we are very nervous if we haven't already seen a bone biopsy result to know whether it's going to be a safe thing to do. So that's my summary.
So would you use rather denosumab or than bisphosphonate in this case, or none?
almost never denosumab in this case, unless I've really got a handle on the mineralization and the calcium dynamics and the bone biopsy. I'm much less confident with that drug because of adverse events I've seen when it's been used willy-nilly.
Yeah. So this was the multidisciplinary team conference in my center. It was in August 2023, so we're quite late to the party. I mean, we probably should have discussed this in the winter of 2023, but it is a new initiative and it takes a while for the clinicians to sort of get their eyes open to the fact that they can get a multidisciplinary team discussion for their patients. So the conclusion, the assessment here was that she has clearly CKD-associated osteoporosis. She has bone fragility. She has multiple vertebral fractures, and as has been said, she's fracturing before our eyes. She has very low bone mineral density currently. We consider it probably as being a lot of pre-existing damage due to severe hyperparathyroidism, long-term on dialysis, possibly calcium malabsorption with calcium drain from the skeleton. And then looking at her alkaline phosphatase levels, well, they are before her fracture start rather in the normal range or just above. I mean, I have seen much, much higher levels of total alkaline phosphatase up to the 300-400 range. So this is not very high to me. So hopefully this is not a sign of a mineralization defect. Also, she does not have the clinical picture of bone pain, which is also often mentioned as a cause of mineralization or as a symptom of mineralization defects, and she doesn't have any clear cause of it in considering hypocalcemia, hypophosphatemia, severe acidosis, vitamin D deficiency, and so on. And so it becomes a sort of a risk assessment of how high do we believe the risk of a mineralization defect is compared to the potential benefit of giving her some sort of treatment to stabilize this condition. So as Pieter said, we didn't find any obvious points to optimize for her mineral metabolism therapy. She has rather normal PTH levels, and despite this, she has fairly high and increasing alkaline phosphatase. Is she in some sort of a high bone turnover state with high bone resorption? Would be very nice to have had a bone resorption marker here, preferably measured longitudinally, which we do not have. Could it be contributing factors such as a large weight loss in the last couple of years? Menopause that may also have come on in these past couple of years, ongoing inflammation, which has caused bone resorption, was some of the ideas that was discussed during this conference. And the recommendation for us was to do anti-resorptive therapy in the hopes that this could stabilize the situation. We do not have good experience using denosumab. I mean, we find it really difficult to treat our patients with denosumab, probably because a lot of them have fairly high bone turnover and are somewhat calcium deficient. We see a very high prevalence of hypocalcemia with denosumab, and typically something that recurs. So we'll give denosumab, have severe hypocalcemia. In 6 months, they will have hypercalcemia. The nurses in our dialysis ward will take away all their calcium supplementation. We'll give the next dose of denosumab and we'll have severe hypocalcemia. It's been really troublesome for us. Also, this is a young patient and we're not sure we can get her on the kidney transplant waiting list. So if we started denosumab, we may be in a situation where we need to continue it indefinitely. So what we actually went with was bisphosphonate therapy.
Good. We will have to round up in a minute now.
So we gave zoledronic acid. We decided to go for a reduced dose of 2.5 milligrams. And the recommendation from our endocrinologist was that we can see how this dose works. So this will be given once a year. So we can give one dose, see the effect on our bone turnover markers, so measure bone alkaline phosphatase every 3 months. If we, after about 6-9 months, see an increase in bone alkaline phosphatase, then we might consider upping the dose the next time she gets the dose. And if we have any severe complications, then okay, we can always back out of therapy with bisphosphonates, which we cannot do so easily with denosumab. So she also has no residual kidney function, so we didn't consider it as any renal risks for her to be using bisphosphonate therapy. Shortly after we gave her bisphosphonates, you can see here she developed hypocalcemia and also hypophosphatemia. And this to me is a clear sign of a hungry bone response. So hopefully some bone remineralization, which is what we want to see.
Thank you very much, Hanne. We are out of time. We can quickly look at the summary and conclusions, please. So if you want to finalize your case,
Yeah, so this to us was a patient with severe bone fragility and multiple clinical fractures. And as I said, to us, it was most importantly that we weigh up the risk of doing harm with the risk of actually giving her some benefits in starting therapy. And this is a condition that really affects her quality of life. She is in pain and she is also of reduced physical function. So it's important to us to do something. We consider the risk of a mineralization defect to be fairly low. And we ended up deciding on a treatment course with anti-resorptive therapy. So I guess the main take-home message for this is that it's important to discuss these cases and to not be too afraid to start therapy, but to think about the potential benefits. We will monitor her, as I said, with bone turnover markers, and we'll also do a repeat DEXA scan in about 6 to 12 months.
Excellent. Thank you very much, Hanne. Thank you very much to the panel. This was really a fantastic case, and it will be very interesting, especially with respect to the strong effect on calcium and phosphate, to see the bone turnover markers DEXA in this case. Let me end the seminar by reminding everybody to come to Leuven in January. We will have the 7th Europe Winter Meeting there, looking at calcification, looking at bone inflammation. Bone and inflammation. It's a very important topic. This case is one of the illustrations of the need to discuss inflammation and bone. So please come, everybody. It's a 3-day meeting, and I hope to see you there. And we also have already scheduled the new case conferences in March 19th, 2024, and May 14th, 2024. So please tune in there. Thanks again to everybody, and have a good night.